case. If you can see a case that I'm sharing here, the patient has nice, thick buccal plate. Clinically also, on a different area, on a different site, you have good buccal plate. So first thing that I do when I remove a tooth is to go and verify the buccal plate. Even if it's flapless, you can get an instrument and go check it. You have the CBCT preoperatively, you know in your CBCT what you're getting with this patient. If the buccal plate is damaged or deficient, this is a high-risk patient. I will approach this slightly differently, maybe not do an immediate, maybe do dual zone grafting to improve the bone and the soft tissue. So always please check the buccal plate. Of course, we don't want any active infection, we don't want pus coming out, we don't want large lesions in the area because that will minimize our success and implant survival. Another key factor in immediate treatment is the available native bone. Yes, you can graft 15 millimeters of bone, but the success of the implant actually depends on the residual healthy bone they have. And that residual bone is found either in the apical portion of the tooth, past the apex, or occasionally you can use the lateral walls of your socket to get implant stability. So in the apical portion, we recommend minimum of 3 millimeters or more of native bone to be able to anchor the implant and get good primary stability. And of course, in a molar site, seeing a septum like this is a very favorable condition because nice thick septum, it will allow me to anchor my implant in that healthy bone and get better stability. And finally, we do not want to ignore the tissue. As the famous saying goes, bone sets the tone, but the tissue is the issue, right? So having a thick biotype gives you more protection. And the way I go about this is this. If I'm doing an immediate implant, if my patient has slightly thinner buccal plate, but they have a very thick biotype, I'll be comfortable doing the treatment. But if I have a patient that has deficient buccal plate and thin biotype, thin tissue, I know that they're at risk for recession, bone loss, so I will adjust the treatment accordingly, either do grafting or maybe not do an immediate and come back to a delayed case. So case selection becomes one of the most important things in these. And some of the additional tools here, this is not product placement. I do love xenograft, a graft that comes from Osstem. It helps me in a lot of cases. Certain cases you use allograft. We can certainly talk about the indications for a long time. But in my hands, to shortly summarize this, the larger the defect, the more xenograft the patient receives. Why? Because xenograft resorbs slower. Some cases it never resorbs actually, and it gives me space maintenance, gives me volume while the new bone is being formed. If the patient has nice, thick, 4 walls, I don't need xenograft in there because the site is protected. You can put allograft and allow for a much quicker turnover of the bone. Another tool, of course, is my resorbable collagen membrane. The purpose of this membrane is to provide cell occlusiveness. Why do I need this? Soft tissue grows 1 millimeter per day. Bone takes 3 to 4 months to grow. If I don't have a cell occlusive membrane, like the cytoplasm membrane, my soft tissue could grow into the bone graft, and my bone graft will not ossify, will not solidify, and I'll have a mush. When you go back to clean it, it's mushy, it's not integrated. And finally, if you can, if you're trained, if you're comfortable doing phlebotomy, using PRF will help you not only with the bone healing, but it also helps with the soft tissue performance. So when I do cases with GBR, for example, I do what's called biological layering.